All right, everyone, we're doing great. We're moving on along to chapter 5 now. Chapter 5 is communication and documentation. So in this chapter, we're going to talk a little bit more about specific things that we need to document in our patient care reports, things that we need to pay attention to, and also just some good communication tips between us and dispatch and the people on scene. First couple slides here are, or the first one at least, is the same that we've seen, the National EMS Education Standards. So the standards that we're going to have for this lesson in particular: documentation, specifically recording our patient findings, and then EMS system communication. So this is going to be our call for resources, transferring patient care to another EMS system or another EMS agency, and interacting within a team structure. One thing that we're going to spend some time talking about is therapeutic communication. And therapeutic communication is specifically how we communicate with our patients and different patient populations, and what we need to do to change how we communicate if it's somebody with special needs, or if it's a child, or somebody who's hard of hearing. So we'll look at a couple of those things. And then we'll also spend a little bit of time talking about medical terminology. As we're entering this field of EMS, it's important that we start using the lingo a little bit, and start speaking like others within the healthcare industry. But it's also important that we're able to shut that off. And when it's time to talk to a patient and we're doing that therapeutic communication, that we're able to use clear and concise communication with them that isn't full of medical jargon. So a little bit of introduction here. Communication is important in everything we do. It starts with the call from the reporter into dispatch, and then from dispatch in through us, and however we get that information. And then we need to be able, as emergency medical responders, we need to be able to communicate with our patients and bystanders, everybody around. We've already talked about being able to communicate with family members on scene. There's a lot of different people involved in this process, and we need to know how to tailor our communications specifically for each of those people. And then after a call, we've talked about documentation and the importance of documentation. But when we're done with a call, being able to clearly put all of that together in a document that can move on as part of our patient care report and as part of our communication with our supervisors and our medical directors and insurance companies and everybody else that needs to know what happened in our interactions with the patient. The purpose of communication is sharing information. And a lot of times we think that just because we've said something that we've communicated. It's one of those times right now where I'm sitting here and I feel like I'm trying to communicate with you, but I'm staring at a camera instead of you sitting in a classroom. And so to make sure that communication happens, there needs to be an understanding of what has been communicated as well. We need to make sure that we understand that there's that part of communication. And sometimes it's not possible to do face-to-face communication. We have a lot of systems in place to help us with that, and we're going to look at some of those systems and how they're able to transmit data for us. So first we have our voice systems. Voice communication is just spoken word. A lot of this is going to be radio communications and things like that. It's important for us to realize that radio communications, at least through the frequencies that we are using as responders, those are regulated by the Federal Communication Commission, or the FCC. And so those frequencies that we are allowed to use for our communication are assigned to us, and each responding agency or dispatch location will have different frequencies assigned to them. So making sure that we're able to get on each other's frequencies and speak with each other is really important. There's different types of radio systems. And so we're going to have like base station radios, our mobile handheld radios, portable radios. And then there's also repeater systems. And those can be towers. You could have a repeater on your vehicle, and it just amplifies the signal so that it can reach farther. Another way that we can do voice communication is what we're probably all familiar with, telephone systems. This is kind of a primary way that we do a lot of our communication. We have landline systems that are tied together through above ground and below ground, like actual hardwire. And then we have mobile phones, which rely on radio waves and tower locations. And some of those towers, depending on how far apart they are or if there's obstructions between them, it can make our communication using mobile phones more difficult. So depending on where you're working, and if you are in a really rural area that has poor communication, it's important to know about different communication types and how you're going to be able to transmit that information that you need to, or receive information from your dispatch center based on where you're going to be responding to, or if it's even possible for you to gain communication while you're out there. We also have data systems, and these are becoming more and more popular. And what you'll see is mobile data terminals. These will be actually located, specifically we see them in our vehicles, but sometimes they'll be at a base location, and they can be used to transmit radio communications, phone, or internet. All of your information can come through in that screen, and you can just see everything available for you. Other data systems that you may see, fax machines. I had to hunt down a fax machine recently. A little more difficult to find. They're still out there, but just know that that is a possibility. We also use telemetry data, and sometimes this will be used by our advanced life support, but also it's becoming more and more common to see these in our basic life support providers transmitting our EKGs or our electrocardiograms to hospitals through those telemetry type systems. So a lot of our new heart monitors have the ability to send that to a hospital so that they can look at it. And it's been great for our BLS services that maybe don't have advanced providers who can interpret those EKGs, where they're able to hook up their patient and send that information to the hospital. And that's one of those things that I think the more we're in this industry and the more technology changes, you're going to see a lot more things like that come about, where we're able to share patient data more seamlessly from our pre-hospital locations to our hospital locations. We also have digital messaging. So this could be our paging systems, email or text, social media. So anything like that that we have for digital messaging. I had mentioned in a previous chapter that there are ways that dispatch can send information through apps on our phones now and actually track where we are as we're responding. So technology always improving, and there's some really good things coming out for us as we continue to integrate data and technology into the EMS field. So the functions of radio communication, like why are we actually trying to talk, and what information do we need to share? So dispatch may be using either voice or text messaging to alert you that there is a need for you to respond. So that's the very first thing that's going to happen, is you're going to get some type of alert that you need to respond. So it's your responsibility to make sure that your equipment is on, that it's working, that it's serviceable. I've had times where I've had my radio turned off, my portable radio, where I turned it off when I was in the truck so that I would maintain battery, and then I would get out and forget to turn it back on, and then you miss that communication. So it is important, and it's our responsibility to make sure that we're constantly available and whatever means possible for dispatch to be able to reach us and let us know that we need to go to an emergency call. If the information is coming in and it's broken, or if there's something that you're unsure about, you always need to reach out to your dispatcher and ask for clarification on that information. A lot of times our radio signals may be blocked from buildings or different things. If you don't have line of sight to a tower or something, it could affect that. So don't be afraid to just ask for clarification and try and make sure that you have the correct information. So we have our response to our scene, and from here, maybe we're using that mobile data terminal. Maybe we're using our GPS on our phone or some other way for us to get the coordinates for where we need to go. Dispatch may give you more information when you're en route, depending on how your dispatch system works. They're probably still on the phone with whoever called 911, and they're getting more information. So they'll update you through your radio or your mobile data terminal, whatever it is that they're using for that. If you're delayed for any reason, if there's traffic, if there's bad weather, anything like that, then we can also use our radio communications to let dispatch know that we're going to be delayed in our response, so that they can relay that to the person who is calling 911. Once we arrive on scene, it's another time that we're going to communicate. Some systems are going to want you to actually perform a visual survey or scene survey and kind of give that information over the radio. It really depends on where you're working, who you're working with, and what type of response you are doing. Like I said, whether it's fire or police or search and rescue, each one of those has a different procedure for what they want when you arrive on scene. But you may get on there, give a brief description, discuss any hazards, number of patients, and additional resources that might be required. And you'll communicate those either over the radio or just verbally with the people around you. It's important, if you are the first one on scene and there are additional resources coming in, that you give them an update when you're able to. And so they're going to be looking for the age and sex of the patient, chief complaint, their level of responsiveness, and then the status of their airway, breathing, and circulation. If you can give just a brief 30-second update on those things for your responding EMS crew, that's going to give them the ability to create a picture in their mind of what they're coming into and help them prepare so that they can help you when they arrive on scene. The other part of that communication is, once they are on scene, you need to be able to clearly and concisely give a patient handoff report to that EMS service as they're arriving. So part of that EMS handoff, or that patient handoff, that you're going to be giving to the advanced providers as they show up, is you're going to continue on with what you gave in that brief 30-second update. You want to give them the age and sex of the patient. You want to give them a history of the incident. So at this time, anything that you gathered from your scene survey, anything that you heard from bystanders, anything that the patient told you, give just a brief description of that. Then you want to describe the patient's chief complaint and use this as concisely as you can: chest pain, headache, abdominal pain, whatever it may be. And then you want to describe the patient's level of consciousness. Are they alert to verbal stimuli, painful stimuli, or unresponsive? And we're going to go through that acronym a little bit later in some of our other chapters, but just give you a little idea of kind of what they're looking for. And then the next thing you want to do is you want to describe what you found on your patient assessment. So some of those things are what you heard, right? And then some of those things are what you actually observed. So make sure that you're able to separate those out and say, hey, this is what I've seen and this is what I was told. You also want to report any vital signs that you obtained on the patient, report any medications or anything that you may have found out about. Another acronym that we're going to use later on as we do our patient assessments is called the sample format, and that is our signs and symptoms, our allergies, our medications. So another acronym that we're going to use is our sample history. That's our signs and symptoms, our allergies, our medications, past medical history, last oral intake, and events that led up to the incident. So we'll go over that more in detail when we're doing our patient assessment. And then the last thing that we want to communicate is any interventions that we've done for the patient. Some EMR services are going to be contacting online medical control, and we've talked about online medical control a little bit, but the reasons that we would be contacting them is if we need permission to perform a certain skill, if we have questions regarding patient care, or if we're actually giving report to the hospital on the patient, and that's where we're doing that brief 30-second. So maybe we're giving that to the hospital instead of giving it to an oncoming EMS crew. And then we have to have our post-run activities. And these are the things that happen once all the dust has settled, once the patient's at the hospital, once everything is finished. This is when you're going to sit down. You've already turned over care, and you're going to let the communication center or your dispatch center know that you're clear of that call, you're ready to go back in service, you're ready for another call. But also, we're going to go through and actually communicate by using our documentation. That's part of the post-run events as well. So here's a little chart just kind of guiding some effective radio communication topics. I'm not going to go over all of them. There's some good things in here that you should look at. Make sure that you're monitoring the radio channels that you should be monitoring. So if dispatch has told you to be on a certain channel, make sure you're there versus your normal response channel. We want clear and concise communication on the radio. Avoid using slang or jargon. I know a lot of places are using 10 code still. That has tried to be pushed out. Law enforcement still uses it. Some fire services still use it. EMS is supposed to just be plain text. So just say what you mean to say and don't use abbreviations or anything. It's also really important to know that we need to watch our language when we're on radios. Any profanity used over the radio is actually a violation of the FCC agreements, and your agency or you could be fined for that. So just go ahead and take a look over this chart and look at some of the different things that are good for effective radio communications. Verbal communication, I already kind of mentioned this, but effective communication means that the person received and understood exactly what you were trying to say. So effective communication requires us to have some feedback. It's not a one-way street. And so the receiver of the information needs to be able to come back and restate what you heard so to make sure that everybody is on the same page. We can be distracted in an emergency situation very easily. Noise from bystanders, from our vehicles driving by us. There's all sorts of things that can distract us. And if we're distracted and we have these external distractions, then it makes us difficult to actually listen and understand what is trying to be communicated to us. The other thing that can cause distractions is our internal distractions. These are the type of things where you're responding to the call, but you're thinking about your sick kid at home, or you just got a phone call that your vehicle that was supposed to be fixed is not going to be fixed in time, and you're trying to figure out how you're going to get home from work, or whatever may happen there. there's a lot of things that are happening inside our mind that can easily distract us from being able to pay attention and be in the moment and understand what is trying to be communicated. And it's essential that when we are at work, when we are in these emergency situations, that our mind is clear and that we're able to focus on the task at hand. So now we're going to move into the kind of that therapeutic communication phase and actually talking about things that we can do to communicate effectively with our patients. So it's really important to understand that communication is not only the words that we say, but it's our body language, it's our gestures, it's our eye contact, it's how we move our body, everything. And so your communication is going to start with that patient as you're approaching it. When you're coming in the door, we talked about our professional appearance before, making sure that our uniforms or our clothing is clean and well kept. So that's all part of how we communicate with our patients. Next thing you want to do is you always want to introduce yourself. And so you just come in and you say, "Hi, my name is Eric. I work with Emergency Training Academy." Ask the patient their name and then use it. All right? Make and keep eye contact with your patients while you're talking to them. And in order to do that, that doesn't mean if they're on the ground, I'm standing above them. I want to get down at their level. I want to be direct eye contact with them. And I want to be able to use language that they understand. Now, I said earlier that we need to understand medical terminology and we need to be able to speak that lingo when we're talking with other medical providers. But we also need to be able to use language that our patients are going to be able to understand. So when we're talking with them, we get rid of some of that medical lingo. So when we're talking with them, we get rid of some of that medical lingo and we just use clear and concise communication. And then we need to make sure and speak slowly and clearly. And that's going to come into play when we start talking about speaking to people who are hard of hearing. The faster we talk, the louder we are, then it's more difficult for them to process that information. It's really important for us in the healthcare industry that we tell the truth. People are going to ask you hard questions. One of the hardest ones is, am I going to die? You get that question, and it's difficult to say, no, you're not, when everything that you're seeing points to the possibility. So you need to be able to balance telling the truth with being too harsh. Tell them, hey, we're doing everything that we can. You're not doing very well. Maybe you're talking about a kid to the parents, and just be honest with them. Don't ever lie to your patients, to the family. Make sure that they are on the same page as far as what you're doing with the patient. Allow the patient time to respond. A lot of us are really fast movers. We want to talk, we want answers, we want to keep moving. Sometimes it's going to take a moment for your patient to process and to think about what they want to say, to think about their response. But also, that can be an indication of maybe some medical problems going on in how they respond. So it's really important that you give them that time and that space to be able to process things. With that, it's also really important that when you are communicating with the patient, you don't let the bystanders answer questions for you. A lot of times we're asking questions specifically so that we can gauge how our patient is doing. And then somebody else will chime in and start answering the questions because they don't want to wait for them to give the answer. And that ties into limiting the number of people that are talking. If it can just be you and the patient, then that's great. Limit all the extra people who are around you and talking. That goes back to some of those external distractors that we have, where as other people are talking, it limits our ability to understand and pay attention and listen to our patients. Like I said before, pay attention to our body language. It communicates a lot to our patients. And then act and speak calm and confident. We are the calm inside the storm for these patients. They are calling us on the worst day possible for them, And for us, it's another Tuesday where we just showed up to work. And so we need to be able to be the one that is calm and brings that calming presence into the scene. We talked about before making sure that we are respectful of peoples and cultures and not judging them or not changing how we treat them based on those things. So it's very important that we respect cultural norms for the patients. I've spent a lot of time around Native American populations, and some of their practices, they want to bring that into the healthcare setting. And you need to allow that and allow other people to help bring those types of cultural norms into the practice for them. Use open-ended and closed-ended questions appropriately. We don't always want to ask yes, no, closed-ended questions, but at the same time, we don't want every question we're asking to be open-ended. Sometimes we do need a direct answer from our patients. So it's going to be a balancing act. And sometimes we ask them direct yes, no, close-ended questions. And sometimes we ask them more open-ended questions where we allow that to flow a little bit more. And all of this really boils down to one important thing, and that is treat them like you would a family member. If you wouldn't walk in and start talking to your mother or your father or your grandmother in the way that you're talking to the patient, then you should rethink that. Or on a flip side, if you were watching a responder come in and talk to your mom or your dad or your grandma, is that how you would want them to be communicating with your family members? So just think about that. Everybody deserves respect. They deserve to have that open and free communication. We shouldn't be guiding the conversations. We should be allowing them the time and space to talk to us, and that we should be listening to them. So talking with patients that are hard of hearing or deaf. Okay, so there's a lot of different reasons why somebody could be hard of hearing. It could be, they've had hearing problems their entire life. It could be long-term deafness caused by injuries or ear infections. It could be a temporary deafness due to an explosion or some other loud noise, whatever it may be. So we need to know and figure out that they are hard of hearing. So if we go in and we start talking to them and it doesn't seem like they're paying attention to us, and maybe they're not quite getting it, we need to ask if they can hear us. Maybe we need to write it down and ask those questions through writing. So with that, identify yourself, point at your badge, show them your badge so that they can read that and see who you are. If you need to get their attention, maybe you can touch them lightly to get them to look at you. And as they look at you, you need to make sure that you have that eye contact so that they're able to see and read your lips. And that helps with communication, even if they're not permanently deaf or haven't been long-term hearing problems, even if it's something that's more temporary because of an explosion or something. A lot of people will be able to figure out what you're saying based on watching your lips move. And then speak slowly and clearly. We're not going to shout. And this comes back to just allowing that process of them to try and interpret what they are hearing, if anything, process your movements of your mouth so that they can piece it all together and understand what you're trying to say to them. Sometimes our patients that are hard of hearing, we may have to repeat or rephrase some of the things that we're saying and making sure that we keep it clear and simple. If all else fails when we're trying to communicate with these people, just go ahead and write it down. Carry a notebook or some way that you can write down and they can write back and forth and you can communicate with each other. Along with hearing impairment, sometimes we have people who are visually impaired. So these people, we need to talk through everything we're doing. And so it's good practice to just say, all right, this is what's happening. I'm going to touch your arm now. That noise is my heart monitor as we're hooking it up. That's what that beeping noise is. And just talk through everything that's happening. These may be new sounds, new experiences for them, and it could be really disorienting if they don't know what is happening. Find out what the patient's name is and use it throughout your examination. That way they know that you are specifically talking to them. And if you're going to talk to a bystander, use that bystander's name as well so that they're able to differentiate between you're talking to that person or you're talking to me. The next thing would be if they have a service animal. So some of these people who are visually impaired is going to have a service animal, a guide dog that helps them get around. Keep those animals as close as you can. Take them with you. There's no reason to separate them at all. And I see this all the time, but just because they're visually impaired doesn't necessarily mean that they can't hear. And so we don't need to speak louder to those people. Non-English speakers, if you're in a location where you have a high prevalence of non-English speakers, it may be that you have people in your department, your police department, your fire department, wherever you are, that actually speak those languages. But if you don't speak those languages, then maybe you can try and find an interpreter. A lot of times we find that the kids, younger kids, have been raised learning both languages and they're able to interpret a little bit. If you have somebody in your department that can interpret, there are great apps on our phones nowadays that can do some interpretation for non-English speakers. And then also, you can supplement your questions and everything by, once again, using our bodies and our gestures. So you'll be able to point to a location. Most people will understand if you're pointing. You could do a thumbs up or a thumbs down and figure out from there and find different ways to communicate with them. So geriatric patients, so these are our older patients. And we don't want to assume that just because they're old that they have any physical or mental impairments. So we want to assess them the exact same way that we would all of our other patients. The one thing that we may see is that it takes them a little bit longer to process, a little bit longer to move. So as we're doing it, give them time to respond to our questions. Pediatrics, familiar objects can be great for these patients. So if you have a toy or a parent or something that you can give them to distract them, to get their attention, that really helps when we're trying to do assessments on patients. It's important to talk to not only the child who is your patient, but to talk to the parents as well. So spend time talking with both of them because the parents need to give us consent for treating the patient, and they're also the ones that's going to be able to answer some of the health questions for them. Ask the parent to hold the child if they're really sick. Most of the time, these kids, they're not going to want to let go of their parents anyways. They're going to want to be cuddled. They're going to want to be close, and allow that to happen. Do your assessment while the parent is holding the child. That is perfectly okay to do that. And it will help the child be more comfortable and allow you to get a better assessment performed. And with all of our patients, we want to tell the child our name and explain everything that we're doing. Give them time to process, start slow. Don't just jump in and start touching and doing an assessment. With all of our communications, like I mentioned before, we want to be at eye level. We want to be at the same level as our patients. And so with our pediatric patients, you want to squat down, kneel down, get down on their level and be honest with them. Just because they're kids doesn't mean that they don't understand what's happening or that they shouldn't be treated in such a way that you're honest and upfront with them. Our patients with developmental disabilities, ask the family member what their normal level of communication is. You want to speak slowly like we would with some of our other special populations. Use short sentences and simple words. And you may need to repeat and rephrase some of the things that you're saying in different ways to help them understand. The other important thing is use the patient's family to help with communication. Just like a non-English speaker, sometimes we need that interpreter, and the family members know the best way to communicate with them. So use them as bystanders, as interpreters, as people who can help you communicate clearly with these patients that have developmental disabilities. Sometimes we're going to have patients who are extremely agitated, who just have extremely disruptive behavior. With these people, we want to try and assess the situation. So once again, this is one of those scene safety issues where we're going to take a step back and we're going to take the time to evaluate what's going on. Is it safe to even approach them? First, we need to protect ourselves and then the patient. So try and stay between the patient and the exit. That is so that you have a clear exit out of there for your own safety. Don't take your eyes off the patient. Don't turn your back to the patient. If you're in law enforcement, you probably know a lot more about how to de-escalate some of these situations, but just the basics of it is make sure that we're in eye contact, that we don't turn our backs to them, and that we always have a clear exit. Sometimes we're just going to have to leave that environment until such a time as law enforcement or somebody else can come in and help us control the situation. As soon as your personal safety is assured, as soon as that disruptive behavior has at least stopped or subsided in some way, then you can go ahead and carry out your appropriate assessments and whatever care you need to on that patient. You can't take them to the hospital against their will, though. And we've talked about this before in what we're doing with our patients. If they are alert and they're oriented and they don't have any reason for us to suspect that there's a head injury or something disrupting their ability to make cognitive decisions, then we can't just take them. They still have the right to refuse. So don't be grabbing and kidnapping and taking patients with you. Now we're going to talk about medical terminology. So it's important to get a basic understanding of some of the medical terms that you're going to be hearing from our physicians and nurses and paramedics and EMTs as you start to work closely with them. So a lot of our medical terminology and things that we use are identifying specific parts of the body, talking about specific illnesses or injuries, or talking about the treatments that were given. It's your job as an emergency medical responder to communicate what you have done, the treatments you've given, as clearly and concisely to other medical providers. So don't use medical terms if you don't know what they mean. So don't use medical terms if you haven't heard them before, if you're not sure what they mean. Use terminology as introduced, looking at each word, and learn common prefixes and suffixes. And we're going to look at some of those here. So some of them that you're going to hear quite frequently. So Brady, so you'll hear bradycardia. Brady just means slow. The next one is tachy, tachypnea, tachycardia. That means rapid or swift. We have therm, which is heat. We have hyper, which means above, so hypertension, hyperthermia. Then we have hypo, which is below. You'll hear that one with hypoglycemia or hypothermia. We also have naso, which is just the nose. Oro is the mouth. We have arterio, that is talking about our arteries. We have cardio, which is talking about the heart. And then our hema and hemo, those are all blood. Neuro is talking about the brain. And vaso is talking about blood vessels. If you understand those simple terms, it'll give you a great understanding of a lot of the things that are talked about in medical terminology. Documentation, we've talked about, and we're probably going to continue to talk about different things and how we need to document. You're going to be using either a written or a computer-based record for all of your patient care records. Things that you need to put in there: age and sex of the patient, the history. So what caused them to call you today, and when you got there, what did you see? How was the patient? What did the patient tell you? You're also going to want to document the chief complaint of the patient, their level of responsiveness, your vital signs, and we're going to go through our sample format and any treatments that we provided for the patient. It's really important to document changes in patient condition. You may have that patient for a long time. It may be an extended period before somebody else is able to arrive on scene and help you out. So we need to be looking at the patient in specific intervals. If they're a critically sick or critically injured patient, we want to be reevaluating them every 5 minutes and documenting if there are any changes. This creates what we call a trend in the patient, and we can see if they're getting better or worse based on what's happening in those 5-minute increments. If they're not super sick, it's not a critical incident, then we can stretch that out to about every 15 minutes, and then we'll still be able to find a trend. It's just over a longer period of time. We also need to document the agency and personnel who took over treatment for us. So it's really important that in your documentation, you say, paramedic Eric Hart showed up and took over patient care. Then it's important to document times. Times help us to put everything into a workflow later and to see if there was a delay in certain patient cares or how long it has been since certain treatments or interventions were started. And so document the times you were dispatched, document the time you got on scene, and document the time that the other providers arrived. At that time, their documentation is going to start matching up with yours. So you want to make sure that those times align, and then what time you left the scene. Documentation also includes any of the reportable conditions that we talked about before. So just a reminder, some of those reportable conditions: stab wounds, gunshot wounds, any suspicion of child abuse or elderly abuse, any cases of rape. Those are things that have to be reported. Anytime that there's an infectious disease exposure, that needs to be reported and tracked, and that's going to be tracked through your local health department. And then anything that's just unusual about the case, if you're not sure about it, communicate that to somebody else and document it. All of these things are going to be put in your patient care report as soon as possible after the call. Some states have a guideline or a recommendation on how soon after a call these patient care reports need to be completed. Your organization may have a specific timeline on when they need to be completed. It's just really important to remember that the longer the time from when that incident was, the harder it's going to be for you to remember specific details, especially if you are going from one call to another call to another call, and then they're all going to start blending together. So documentation as early as possible and as clearly as possible. So now we're going to move into our summary. We're just going to make sure that we understand communication systems allow us to relay information from one location to another, whether it's face-to-face or whether it's through some other type of voice or digital communication. Communication means that not only is there the spoken part of the communication, but also that we understand what has been communicated to us. We need to understand the basic idea of how our department's communication system works, whether they're using digital systems, voice systems, if they're texting, if they're using apps. Make sure that you know how that is and how to troubleshoot problems with those communication devices. Make sure that you're familiar with two-way radio communications and have a working knowledge of mobile and handheld phones and radios. Communication systems are used for different functions. The phases of EMS go from the moment that there is a response and somebody has noticed that we need to have EMS called, to dispatch, to the response on scene, your arrival on scene, the treatment that you've provided, updating the incoming EMS crews, up to when you hand off care or are transporting the patient. It's important that you understand and follow standard procedures and protocols for your department when it comes to communication and how you're going to communicate with the dispatch center, with the oncoming or incoming EMS systems, police departments, fire departments that are coming to the scene to assist you. Along with our radio communication, it's important that we have good therapeutic communication with our patients and understanding how we need to communicate with them and how we can tailor our communication based on special needs that they may have. Remember that body language is a huge part of our communication, and the more that we pay attention to our body language, it will help us with those people that have special needs. Remember, your call isn't complete until your documentation is complete. So make sure you understand the process for how your agency wants you to complete that documentation, in what time frame they need it done, and how much documentation they're looking for. We're going to go into our review for this chapter. So question number 1, when communicating with a sick or injured person, it is important to use terms such as dear and baby when addressing the patient, only use medical terminology, ask the patient as little as possible, or maintain eye contact with the patient when you can. The answer is D, maintain eye contact with the patient when you can. Question number 2, which of the following can be considered good communication? We have, you talk louder so you can be heard over the television. You initiate care without telling the patient what you are doing. You assess the patient while thinking about your last call. You minimize distractions during your conversation with the patient. We're going with D one more time on that one. Minimize distractions during your conversation with the patient. Our last question. When caring for a pediatric patient, you should consider separating the child from the parents to avoid upsetting them, speaking in an authoritative tone, allowing the parent to hold the child if the situation permits, or performing painful procedures without giving the child any warning. And we're going to break from tradition. We're going with C on the answer on that one. Allowing the parent to hold the child if the situation permits. All right, guys, that was chapter 5. You're doing great. See you on the next chapter.